in a larger sense, this talk is really an extension of Jim Lowe's talk this morning, because he said first you have to know what is happening, and this is about trying to figure out what is happening. So in this particular, every good project needs a team, and in this particular project, Dr. Marissa Bertolo is a team leader, statistical support is here, technical support, and then we have camp followers and hangers-on following up. So just for clarification in terms of vocabulary, I like Roger Paskin's definitions of surveillance versus monitoring. As Roger points out, in practice, surveillance and monitoring are usually used interchangeably, synonymously, which is actually incorrect. I like his definition in which he says surveillance is about detection. So if we surveil for foot and mouth, we're trying to detect, whereas monitoring is tracking changes over time. We may want to see what's happening with PRRS over time in endemically infected herds. In this particular presentation, it doesn't matter which one we're talking about, because we're going to talk about sampling, and whether you're looking at surveillance or monitoring, really these numbers apply to both. A brief history on surveillance. Representative sampling, as we have come to know it, was first described here in 1895, mostly ignored until this incident in 1948, in which Dewey is credited with winning the presidency. Before this 1980 or 1895 business, the practice was to sample everybody or everything. So representative sampling a subset, really came into strong practice after 1948. In classical swine fever, when the U.S. took on classical swine fever eradication, here's a picture 1963 showing the beginning of that program. Here's important years, 59, 64, 69, and 78. What I want to point out to you is the number, this is the average total inventory, average total number of pigs on a farm. So with the classical swine fever eradication program, it was practical, and it was put into practice to sample every pig on a farm. And so here's some examples. Here's where you could do that. This is Khrushchev cruising around the farm in 1959 with Roswell Garst and Cabot Lodge. This type of facility is amenable to these numbers, and it is practical to surveil all animals on these farms. Here's where the pseudorabies program comes into play. We began developing the technology to eradicate pseudorabies in the 1980s. As that technology came into place, the question of representative sampling also came into play. And so there was an important meeting in Peoria, Illinois in 1986 where the heated debate was about, do we continue sampling all animals in a herd, or do we go to representative sampling? And in that case, representative sampling won. What I'd like to point out to you is look at this average total inventory, how it is exploding over time. In the Marshall County pseudorabies eradication pilot project, the largest herd, we considered it a mammoth. This mammoth herd had 300 sows. 300. In the pseudorabies eradication project, this was the policy for sampling. You had 95-10 sampling, 95% probability of detecting a 10% infection, and here's the numbers. You used 95-5, 95% probability of detecting 5% infection, or you did a 95-20, in which you sampled basically 14 head. This sampling policy is where we come to the normal, what we consider normal sampling policy of selecting 30 animals. It came from this era. Here's 29, we just rounded up to 30. But where do these numbers come from? They didn't necessarily come from this book. Cannon and Rowe published 1982. Cannon and Rowe acknowledged that the fact that they pulled these kinds of tables from statistical texts. But nonetheless, you can see here's our, for herds of 1,000 or greater, sample 29 animals. And that was where that came from. Now the question is, where do these numbers come from? Or these tables come from? And they came from specific assumptions. The specific assumption is that our targets have a hypergeometric distribution in the population. And what that means is we have a finite population, which is true, We have a binary outcome because our diagnostic tests are either positive or negative. We have to assume that we're assuming that every observation is independent, and we're assuming that the target, whether it's PRRS or pseudorabies, is randomly distributed in the population. I put the question to you, are these true here and here? Assuming you have hypogeometric distribution, you can use these kinds of equations and build those tables. Here's the problem we're facing right now. The problem is we're facing these ever more complex systems. So, for example, if you look at these numbers from 2012, 60% of our inventory is on farms with greater than 5,000 animals. Remember, we started out with, in classical swine fever, with about 40 animals. Now we're up to 5,000. We only have about 18% of our farms, and this was the 2012 data, 18% of our farms have 1,000 or fewer. So we've completely shifted the kind of populations from this approach to this approach. We recognize that as veterinarians trying to deal with these issues in the field, and we try to do different things. We've tended to move away from these individual pig samples to either pooled samples or aggregate samples. And I would differentiate pooled from aggregate in the sense that pooled samples, by definition, first you collect a sample, and then you precisely mix those samples as you want. Aggregate samples are already mixed at the time you collect them. And so good samples or good examples of aggregate samples are bulk milk tank samples, where all the cow's milk goes into one tank. Other examples are oral fluids or air samples or water samples or Swiffer samples. Next one, please. Okay, so I was heavily criticized the last time I gave a talk because I didn't go through this thing about what oral fluid samples are. So I beg your patience, we're going to go through what oral fluid samples are in about 30 seconds. Next slide, please. So collecting oral fluid samples. We use cotton ropes to collect oral fluids from pigs. By suspending the rope in the pen, and then the pigs naturally play with the rope. Next please. We recommend collecting in the morning, first thing when pigs are most active, using the cotton rope, adjusting the rope to the sides of the pigs, and then simply extracting the fluid. Next, please. This is a sample that's been around for a while, which is why it surprised me when I was requested to review this in the last talk. But we've been using oral fluids since about 2010. These are the numbers from Iowa State. 10,000 samples in 2010, increasing almost every year, or essentially every year. 2015, we ran 176,000 samples. 2016, about 178,000. We see here this decline reflects the absence of government funding, government support for PDV testing. And so this is probably our new norm, and this would get us about 100,000 samples every year. There's descriptions of PCRs for oral fluids for virtually every swine pathogen. Next, please. As well as antibody assays. And this holds true in our experience, which is any pathogen for which we have a good serum ELISA, we can adapt to detection of antibodies in oral fluids. Next, please. So here we go back to our real question, which was how to collect oral fluid samples in a statistically valid surveillance approach. We haven't had this kind of guidance up to now. Statistically valid methods to collect oral fluid samples. And in particular, we're interested in answering the question of how do you allocate samples? Because you have this complex system here. How are you going to allocate samples? And what number of samples do you need? And frequency of samples. We made this assumption from the beginning that our numbers have to be at the barn level, not at the site level. Because of the fact that these animals, these barns are filled by different animals at different ages and stages. The barns function on their own. When one group of animals in a barn is finished, that barn is emptied and then refilled. And so we have this shifting equilibrium, if you would, on a site. So our estimates are going to be at the barn level. Next, please. So to look at this kind of thing, instead of our hypergeometric distribution and our hypergeometric sample size formula, we're going to use what's called a piecewise exponential survival model. And this is what that looks like. And we're going to look at the questions of allocation of samples and number of samples. Next, please. We're using field data that Dr. Rotolo collected in 3 wean to finish barns on one site, 36 pens per barn, exactly 25 pigs per pen. Sampling occurred from the time they were first placed and then for an additional 8 weeks. So we have a total of 9 samplings. Next, please. And this one, can you go back just a second? Just so you notice, these pens have concrete walls, which we think, from the literature, you would assume is going to affect the rate of transmission between pens. Just so you know. So these are, our assumption from that is that these are relatively conservative estimates. So in total, 972 samples were collected from these 3 barns. That's 3 barns by 36 pens by 9 samplings, so 972. All the samples were randomly ordered and then tested by PRRS PCRs. No retests. So a single swipe and then look at the analyses. What you're looking at here is a movie of what actually happened. The darker the blue is, the more virus there is. And so here's our 3 wean to finish barns. This is going to start again. Each of these squares, rectangles, is a pen. Here's beginning of sampling, and then you can follow the process over time. Look what happens between week 4 and week 5. So we see this explosion of PRRS across these buildings. This is next, please. We can go to the next one. This is some data from Dr. John Roberts looking at field groups, and what he said was groups with an initial prevalence of 8% took 5 weeks to reach 100% prevalence, and that's exactly what we saw. So the point I'm trying to make is that our field data match what was already in the literature. This was published, I think, 2003. So we see in our 3 barns that there's really somewhat different patterns of replication, even though these barns are only 40 feet, 50 feet apart. Next, please. It matches what Dr. John Roberts described. Next, please. So we're still left with the question, what is our plan for a statistically valid approach for oral fluid sampling? Next. So, and we're back to our model, and back to the questions of allocation of samples and number of samples. Next, please. So by allocation of samples, we really have 2 choices. We can do random sampling, and this is an example using a random number generator. So we can go to random.org and list the number of pens and to ask random.org to tell us which pens to sample. And this is what you get. This is a random sampling. This was actually done. And you see that the pens we're going to sample are randomly distributed, although they tend to cluster. Here's a cluster and then a big hole. So here's what we're calling fixed spatial sampling. And by that I mean equidistant spacing across the buildings. So in this case, you would decide how many samples you want to collect and then space them equidistantly across the buildings. And our argument is going to be that sampling the same pens over time gives you extremely good results. Next, please. So there's a bunch of numbers here. There's some tables. These data actually are coming out of a publication beginning of next year. My counsel is, don't worry about the details. Think about the concepts and consider if you think they're worthwhile. Next, please. So in this case, we're looking at the number of pens sampled, and we're looking at the probability of at least one positive sample across different levels of prevalence. Here's 1 of 36 pens being positive, 3 positive pens, 6, 9, and 18. So we're looking at 3 things at once: prevalence, the number of samples we're collecting, and the sample allocation. Remember, sample allocation is either random sampling or fixed spatial sampling. Now, random sampling is the line with a dash, and fixed spatial sampling results is a solid line. And you see that there's a slight difference between random sampling and fixed spatial sampling. It would be random statistics if there was any difference in the rate of detection, in the probability of detection. The difference was in favor of fixed spatial sampling. So fixed spatial sampling was as good or better than random sampling. regardless of the number of pens, over time. Next, please. So the publication that's going to come out is going to have tables that would be similar to the tables we had in Cannon and Rowe in 1982, in the sense that they're going to give you the number of samples to collect as a function of prevalence. Here's sample size, prevalence, and here's the probability of detection. Fixed spatial sampling equal to or better than random sampling. So fixed spatial sampling is not something that we've used widely in veterinary medicine. There's only a couple of examples. However, systematic sampling is a more precise than simple, should be more precise than simple random sampling when spatial autocorrelation is present and the sampling effort is equal. Spatial autocorrelation. Spatial autocorrelation is an important thing, and I recommend that you take a look at Dr. Bertola's poster, which is on display. If you remember from our assumptions on hypergeometric distribution, we said that the results had to be independent. What spatial autocorrelation means is that the result from one sample has some power to predict the result for the next sample. That means that we have a problem with hypergeometric distribution. But the advantages of spatial sampling for us is that it's a really easy concept to understand. It's easy to explain to anybody which pens to sample and when to sample them. This is an approach that's widely used in forestry and environmental sciences, and there's no reason we shouldn't use it as well. Next, please. So here's Dr. Bertola's poster, Spatial Autocorrelation and Implications for Oral Fluid-Based PRRS Surveillance. She also had a talk Tuesday at 8 o'clock at Kerwood, so if you're around, I'd recommend you attend that. Next, please. Here's the next important concept. So we've got numbers for how many to sample and what the probability of detection is as a function of prevalence. But here's a really important concept as well. Detection on the site depends on the number of barns sampled. Next, please. And by that I mean using this equation, the probability of detection as a function of the number of barns on the site can be calculated. Note that the n here is the number of barns sampled. So this is 1 minus the function of failing to detect. Next, please. So let's look at an example. Here's one example. We're saying that there's 3 positive pens in a barn. And we are going to use this function from the table. We're saying that we have a diagnostic sensitivity of 95%. At this prevalence and this sample size, if we collect 2 samples, we predict a 16% probability of detection. If we have 4 pens sampled, we predict 30% probability of detection. And if we sample 6 pens, 42% probability of detection under this level of prevalence. However, using the equation that we just showed you, if you start multiplying that across barns, look at what happens. Even if you only collect 2 samples per barn, yes, in one barn, your probability of detection is only 16%. But if you sample 3 barns, it goes up to 41%, 5 barns, 58%, 7 barns, 70%. If you increase that number, of course, in each barn, you also increase the probability of detection. Using this approach, your ability to detect PRRS virus on a site is extremely high and pretty damn cheap. Next, please. So fixed spatial sampling also works for monitoring. Just a quick example. Next, please. Remember, we said there's surveillance, which is about detection, and monitoring, which is about looking at change in trends over time. So here's an example: 10 sites, 6 pens in each barn, sampling every 2 weeks for 18 weeks. Next, please. And here we see these animals came in. You see the decline. We have both ELISA SP values and PRRS PCR results. So this red P in each of these cases indicates a positive PCR on an oral fluid sample. So what we're seeing here is a decline in maternal antibodies. These guys come in, they go negative, and then almost simultaneously you have a PCR positive result as well as an antibody response. In each case, this monitoring is quite effective, easy to interpret. Decline in maternal antibody, bingo, PCR positive, antibody positive. Here's decline in maternal antibody, and then in sequence PCR positives as well as increases in antibody. Next, please. So logical, easy to understand. So you can reflect, you can see what's going on over time. Maybe you can't do anything on this particular barn, but you're going to know what's going to happen or what has happened and take measures to stop it in the future. I think the part that Jim didn't get to is why and then what to do. This gives us some information about what we should be doing in the future. Next, please. So this example we use directly was using an example with PRRS PCRs, but there's no reason that our model would not apply to any pathogen assay combination. So PRRS, antibody detection, any pathogen you can think of. Next, please. So, our conclusions, my conclusions, sampling recommendations should apply to any oral fluid-based test. Use fixed spatial allocation. It's easy. It works either for detection or for monitoring. And in terms, as we start expanding or continue to expand this area or regional projects, this would be a great way to find out exactly what's going on in farms and apply it at a regional basis.